You can go first.
So the problem I identified was the identified problem is the relation of teens and adolescents who currently smoke e-cigarettes have been developing lung-related problems. And what are the data and sources of information that validate Helen? I said safety and risk management concerns because me personally, when I was at clinical, I got a 20-year-old male who developed a collapsed lung after smoking and ruined air. Why is the problem important and relevant, and what would happen if not addressed? I said large amounts of young adults and teens are developing lung problems when using an e-cigarette. This includes problems such as collapsed lungs, pulmonary embolisms, etc. If not corrected, more young adults could die from problems like this, just because a lot of them won't go in just because I don't know, they just don't really identify that that can happen from an e-cigarette, and I don't think the dangers out there are really notified yet. The FDA has not regulated any flavored e-cigarettes yet, specifics like the disposable ones, which are commonly most used, and then therefore many kids can buy them off the streets, and older individuals can still buy them if they are age 21 or older in the state of Minnesota. Is this a background question to establish the state of evidence on a topic, or a foreground question to compare some specific interventions? I said foreground because I'm going to be comparing to educational programs versus no educational program, so it's not just a background question. So my PICO components, P, which would be population, is teen or adolescents who vape currently or use e-cigarettes. Intervention would be a brief educational program, which we can define later, like what specific program we're talking about. Comparison would obviously be no intervention or program, and the outcomes that we want to occur would be leading to smoking cessation. Initial evidence-based question would be, do children aged 12 through 19 who report the use of e-cigarettes benefit from a brief educational program rather than no intervention in order to achieve the outcome of smoking cessation? And then possible search terms ahead were teens, adolescents, e-cigarette use, educational program, cessation, and then I figured once we could search more, then we could determine more educational programs for search terms.
Cool.
Yes.
Do you want me to go next?
Yeah, go for it.
So my problem, I talked about reliance on like opioid medications for pain relief measures post-operatively, and just like the opioid crisis and how people are becoming dependent more recently. Why is the problem important and relevant? I said increased risk for patients to become dependent on opioids for pain management, increased risk for depression if they have unresolved chronic pain, decreased wound healing abilities from stress, decreased mobility and sleep disturbances, decreased ability to complete ADLs, and patient safety risk for respiratory depression from opioid use. The current practice just for medications would be like opioids, NSAIDs, that stuff, and non-opioid current practices are usually like hot and cold therapies, massage, acupuncture, distraction like TV, reading, coloring. How is the problem identified? I said safety and risk management concerns, and then I also added unsatisfactory patient, staff, and organizational outcomes, just because like unsatisfactory patient outcomes could be like respiratory depression. And so my intervention that I want to include is virtual reality, which is being used more often now. So my PICO population would be post-operative patients. I would be engagement in virtual reality. C, patients only receiving opioids for pain management, and outcomes would be pain ratings. And my initial evidence-based question was, in post-operative patients, how does engagement in virtual reality affect pain rating scores compared to patients only receiving opioids for pain management? Some terms I said, like virtual reality, VR, post-operative, post-surgical, pain management, narcotics, opioids. What evidence must be gathered? I said publications, organizational data, maybe on like how different there are different narcotic policies and stuff like that, and position statements like how like nursing boards want narcotics and pain management to be addressed. And then I revised it a little bit to kind of narrow down the search criteria. So in post-operative patients already receiving opioids for pain management, like how does the addition of virtual reality affect pain rating scores compared to like it's patients who have VR and opioids rather than patients who are just receiving opioids. So like if the patient's receiving VR, do they require less opioids for their pain management, stuff like that. And then outcomes measurement plan, I just said like our measurement is pain rating scores. How will we measure it? Using numeric pain scales. How will we measure it? Usually opioids are administered every 4 hours. Where do we obtain the data? Online publications, or like if we were to go into hospital units, it would be post-surgical units. Who will collect the data? Nursing staff and or research staff. And to whom will we report the data? And then I said hospital management or policy creators who would make, who would change the policy on like opioid criteria or the use of virtual reality instead of that. And that's it.
Very cool.
I can go next. So my problem is patients with end-stage renal disease who usually get hemodialysis like Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, and if they experience like an acute health event, oftentimes they're placed on CRRT, which is continuous renal replacement therapy. So usually patients on hemodialysis are completely anuric, but if they switch over to CRRT, the level of fluid being taken off is titrated more, and sometimes they become oliguric rather than not producing any urine at all. So the problem is if a patient is diagnosed as anuric and they start producing urine, we don't really know, so you have to bladder scan them basically. The current practice is I don't know what the current practice is. I don't think that there really is one. So I have to look into that. But the initial evidence-based question is for anuric patients with ESRD on hemodialysis. What is the effect of continuous renal replacement therapy on urine production during hospitalization for acute health events? Some of the possible search terms would be for ESRD, CRRT, hemodialysis. And then intervention would be, I would search bladder scan, straight cath, and then see the comparison would be no intervention, and then the outcome would be oliguria or like UTI or stagnant urine or something like that. And then I think this is a foreground question, but I'm not quite sure. Yeah,
I would say it's for
okay.
Yeah.
So why is this problem important or relevant? Well, if we have a patient that is admitted as anuric, that's kind of like just what every oncoming nurse or care provider would anticipate. But if they start producing a little bit of urine, even if it's like 50 mils a day, like if they're there for like 2 weeks, that can be like a lot of urine, and it can cause problems. Especially because CRRT is really reliant on like a lot of fluid balance, like I's equals O's or whatever they have to titrate it really carefully sometimes. And then let's see here. So the data and sources of information to validate, I said so like a lot of like the flow sheets I think would be like a collection of data from flow sheets of this specific patient population would be a source of information. And then of course any other the evidence to be reviewed would be peer-reviewed publication, clinical practice guidelines, standards, and the measures that would indicate if the EVP project is successful would be bladder scanning on CRRT patients prevents development of stagnant urine and UTI. I think that needs to be honed a little bit more. So that was mine.
Very nice. Cool.
Alright, so for mine, The problem had to do with nurse to patient staffing ratios are decreasing the quality of care for patients. During my research, I found that one of the things that nurses are like starting to do is advocate for themselves, and they're saying it's just not safe to come in and take on so many clients. The highest number I saw for a nurse to take on or a nurse to clients was 16, which I thought was insane.
There's no way.
That's what I thought too.
That's probably at like long-term care
Well,
facilities, which is common at long-term care.
But still, I was like, that's ridiculous. And then, let's see, why is the problem important and relevant? This problem is important because patient-driven care is a primary goal, and to see the quality decrease goes against what is best for the patient. If this is not addressed, we're going to see a couple things both for the patient with decrease in care, which could mean increase in mortality, and then like increase in readmissions to hospitals, and then also on the employee side, just nurse satisfaction, nurse burnout, which then kind of decreases the number of nurses available to provide care. The current practice, there is no federal standardization, there's no state standardization either. It's kind of, or in most states there's no state standardization, but it's kind of just facility based and figuring out what specialty needs what and like the acuity of patients. I said this was a foreground question, so you'd be comparing how things were prior to the increase in patients to nurses. The PICO components, nursing staff, patients, and then intervention. So having a standardization of like a policy for nurse to patient ratio with keeping in mind specialty and acuity. Gonna be, like I said, comparing prior metrics and then outcomes. We'd be hoping to see improved patient care. Some of the search terms put nurse ratio impacts, nurse ratio policy changes, effects of nursing staff ratios, negative effects of nursing staff ratios, patient care, quality of patient care, improvement in patient care. Some of the other things I could just add in here that I thought of would be, like I mentioned earlier, the decrease or increase in mortality, increase in readmissions to the hospital, and then the revised evidence question. I think I did this right, but you guys let me know. What or would patient metrics of readmission rate, decrease in mortality benefit from standardized nursing ratios? And those two metrics would be determining if this project is successful. So, yeah.
Cool.
I like it.
Okay, so now do we have to work on
So
a
now we have
development template?
So now we have to pick, so identify what you want to answer with a clinical question. So what question do they want to pick?
I like yours. That's kind of a unique.
VR?
That Jacob's is really important too for anyone.
Yeah. The only thing I would say is, did you by chance look if there's research on virtual? Is there a ton? Okay, cool. Because I did a PICO development before, and when you start researching, you have to make sure it aligns with every single component. So like,
Oh yeah, you did this for your undergrad.
and I had to restart because I found no evidence based on my question, because my question would not answer any research that was out there, which is hard to believe, but you have to make sure like your population's the same, your intervention, comparison, and your outcome are all matched by the article.
Yeah, I kind of made the template going off of a research study so that it would
Yeah,
kind of align, it would make it easier a little bit.
Yeah. that's perfect. I'm in for that. And then if we end up, for whatever reason, running into it, I say then we
Yeah.
go to Jacobs, because then I think there'll for sure be evidence on that after the COVID.
Oh, yeah.
Yeah, there is, I had to do a little bit of writing for that.
I'm
for a
actually
different class.
writing that for my other paper.
Yeah,
Same. Am I? I think
So-
I am.
are we gonna keep recording or do we need?
Yeah,
Yeah,
so,
'cause
because now we go to, so yours is a therapy intervention template.
Yeah.
So we'll scroll down. You can choose A or B. So we're gonna see whatever matches. It did say utilize the T timeline only if it's relevant. So we don't really have, in your question, you didn't say like within a certain amount of time,
No.
right? Okay.
No.
So you can ignore that part then. So you would say like where was your question for? Your direct PICO question.
My direct PICO question. This one. In post-operative patients receiving opioids for pain management, how does the addition of virtual reality into care affect pain rating scores
So-
on opioid dependence?
Should we go
Maybe B?
B?
Yeah.
So I don't think it lets me click because I upload it to Google. So we'd say post-operative patients. What is the effect of receiving virtual reality?
Yeah. Or I said engaging in the first one. What's the effect of engage?
Of engaging in virtual reality
So we're doing the therapy intervention template B.
On pain, numeric pain rating scales?
what is that called? The specific scale.
I think it's numeric.
Okay.
Reports?
So in postoperative patients, what is the effect of engaging in virtual reality on numeric pain ratings? We'll say on the numeric pain ratings, okay? Compared with opioid use?
Compared with patients only receiving opioids. Or solely receiving opioids for pain management.
So the C is
So we delete the T because we don't have a C.
time frame.
Or
The
T,
C would
we
be
don't
a
have a T yet.
comparison of just opioid use.
So can I erase all the other templates to get this out of the document?
Yeah, I think so.
Okay. Oh, whoops, I'm not on the right one. We're on the. I'm not on the one that we're sharing. Okay, now I'm on the one that we're sharing.
Why did you decide to pursue this clinical question? We could say, I feel like it's a very important right now because we're in the middle of an opioid epidemic.
Yeah, it's been like a long time too.
Yeah.
Epidemic.
Just finding alternative like ways of treating pain. It's pretty cool.
Also,
I think it's
like,
also like a very new industry that like the people are still figuring out I don't even know how to put it. They're still figuring out the applications to it and it can have a lot more, so this kind of opens the door for it, I feel like.
also like it's always good to have non-pharmacological pain interventions because there's no side effects usually.
Yeah.
So
True. I never thought about
well, sometimes I feel like VR you might get like vertigo.
Maybe.
Or I would.
Yeah.
I can't do it. Alternatives for pain management.
Mm-hmm.
Did I miss anything like
It could be what's the word? Is it adjunct to like you can use
Yeah.
pharma and non-pharma, right?
Yeah.
So you could use both.
Yeah.
It would increase the efficacy of opioids potentially, right?
Yeah.
In that scenario.
Mm-hmm. So it doesn't have to be an either or, it could be a slow like decrease or
Yeah.
whatever.
Yeah, like, exactly.
Keywords that you can use in your evidence search.
And we can add from it.
Oh, good idea.
So I have, whoops. I've got virtual reality, VR, post-operative, post-surgical, pain management, perceived pain, narcotics, opioid dependence.
Addiction.
Yeah.
Chronic pain.
Would it be
Tolerance.
chronic pain, or if we're specifically focusing on post-operative, it would
It
be
would be
chronic?
acute pain.
Are
That
we
would be
focusing on?
Yeah, so
Post-op.
that's where you,
Gotcha,
with your
gotcha.
key search terms, we have to be careful with
Yeah.
the chronic pain.
Because I feel like totally different
Yeah.
animal.
Right.
What was the other one, tolerance?
Um,
Dependent? Oh no, we already.
narcotics. Did you
Gotcha.
include? Oh, sorry. I think that's a lot, but
Yeah, I think that's good.
oh, you could do post-op, or you got. I keep saying things that you have. Oh my god. Yeah, I think that's good.
Okay, cool.
Just gonna check. I might put them in like bullet points, so it'll be easy for
Okay,
us. Just
that's fine.
copy and paste.
Mm-hmm.
Should I stop our recording?
Oh, sure.
We're good.
21 minutes.